I'm very pleased to be here today, very excited. This is our third academic coaching workshop through the CBME office, but our first via Zoom. And so it's definitely an exciting time for all of us who are going to be leading some discussions today. I'm Irene Vasilis, like I said, pediatric endocrinologist, program director, and the chair of the Faculty Development Committee for CBME. And today we're going to be talking a little bit about the role of the academic coach. And I'd like to introduce to you on the next slide the team that has been involved with the development of this great workshop. There's Lisa Kalisa from the CBME office, Mike Parrish from anesthesia, Naveen Sidhu from PICU, Heather Whittingham from CCU, Ranish Gupta from PICU, Mary Zakos from pediatric GI, and Blake Yaraskevich from neurosurgery. And it was a great team effort, and these are going to be your facilitators for today. And they will introduce themselves more within the small group format. On the next slide is the objectives. And before I start talking to you, oh, maybe not. I start talking to you about kind of why we're doing this today, there's just a few housekeeping things that I'd like to ask of everybody. There's about 77 participants registered for today's session, which is great. It does mean, though, that there's 77 potential noise factors. And so I would ask that everybody mute themselves during the presentation. This is an informal kind of workshop. We do want to encourage participation as much as possible. So if you do have a question, please feel free to unmute yourself and ask the presenter. It's, like I said, informal. We have also experienced some bandwidth issues previously on Zoom where things have been slowed down when everybody is on video. So because of that, our ask is take yourself off of video for now. And once we've broken into our smaller sessions, our smaller groups, our Zoom rooms, that you please put yourself back onto video at that point where we're going to be doing smaller group discussions. So for the larger sessions where we're in right now, please mute yourself and take yourself off of video. Unmute yourself. If you've got a question, please feel free to use the chat option as well. So, I mean, to start with, this whole concept of academic coaching, it's something that's definitely come to the forefront of the literature and definitely discussions in the recent few years. But it's not a concept that's new. And I mean, even in 2011, Atul Gawande, who's a well-known surgeon and a great author, has asked, you know, top athletes and singers have coaches. Should you as a physician have a coach, or should you as a physician in training have a coach? And so with that thought, I kind of say, well, I think a lot of us around the table today probably think so, either that or you've been asked or told that you need to be a coach. So let's talk a little bit about that. And so the Royal College has adopted this coaching model, and the thought about coaching is that it's really this one-to-one conversation where the coach is focused on enhancing the learning and development of the coachee, primarily by increasing self-awareness and that sense of personal responsibility. The coach is there to truly facilitate that self-directed learning through asking some probing questions, listening actively, and appropriately challenging the learner in a supportive and encouraging climate. And where you see that this is really the distinction, and we're going to talk a little bit about some distinctions of coaching versus other roles, is that facilitating that questioning, that reflection, pushing or trying to take the learner not just to competence, but to their personal best, and giving them that environment where they can thrive and think through that process. And so we all wear multiple hats every day, whether we're learners or faculty and staff, clinicians, educators, or researchers. And so we put them into little boxes, but really that's a little bit artificial because there's definitely overlap between teaching, mentoring, and coaching. But really at the end of the day, teaching is kind of almost one directional. It's the transmission of a specified body of knowledge to skills to a learner. And that we do every day. We do bedside teaching, we do didactic teaching, we teach about research, we teach about education. And then there's mentoring. And the mentor is really guiding the mentee to achieving a performance and career path. It tends to rely on perhaps some lived experiences of the mentor and telling or advising the mentee what they think would be best for them. And then there's coaching. And coaching is really a lot of conversation, bi-directional, a lot of discussion, where the coach is really just facilitating that reflection from the learner about where they're at and where they'd like to go to, and helping them set those goals for getting there and holding them accountable for it. Whereas with mentoring, it might be a conversation with maybe not much of a timeline for achieving the discussion points or being held to those discussion points. Coaching is very much about where are we going to get to? How are we going to get there? How are we going to know we're going to get there? And we're going to circle back to this at the next meeting. For coaching to happen and for this whole new mindset, I guess, of medical education, it's really important to understand the growth mindset of yourself as coaches as well as the learner that you're coaching. And so it's really looking at shifting that mindset from a fixed mindset where there's the belief that there is an achievement, a level of achievement that's predetermined, and that regardless of what effort you will do or the learner will do, that it's not going to create or promote any greater achievement. Where there's this desire to prove something or avoid looking dumb or unintelligent. Where the learner is always asking, will I succeed or fail? Will I look smart or not? And really tries to avoid constructive criticism. That growth mindset that we're trying to get all the learners to through this coaching is really the belief that there is a potential for individual growth and improvement, that it doesn't get capped. And it doesn't get capped at competence. It's really towards excellence that we're driving. That the learner wants to learn and looks for opportunities and challenges to really challenge the current status of their learning. And that we as coaches are promoting that. And we're promoting them looking at these opportunities for direct observation as opportunities to challenge themselves and to grow. And really getting them to believe that growth and learning requires effort and time. And that's what coaching is all about. It's about this longitudinal effort and time, and helping them learn from feedback and using it to practically improve. And so that's where the shift is happening, and that's where we're really wanting to focus with CBME on this assessment of learning, taking, tests, exams, ITERs, these summative assessments that are high stakes, happening at the end of a learning process that are really poised to just judge or evaluate learning at a particular time, to more of an observation for learning. So taking opportunities, multiple opportunities daily to observe, to give formative assessments that are low stakes in a safe environment, to take these opportunities and embed them in the learning process, make them frequent and ongoing so that they're part of the culture, really for the goal of monitoring learning and progress rather than judging, and providing immediate, timely, and formative feedback that can then help the learner improve themselves and create that feedback loop. And that's where Competence by Design has really started. It's the Royal College's initiative and initiatives from around the world. It's not new, and it's really to improve a lot of things, but it's improving patient care, or at least the assumption of patient care, by assuring that our residency programs facilitate the development and acquisition of competencies. And it's doing that through two ways: by competency-focused instruction and by this direct observation and work-based assessment. And now I'm going to hand over to Heather Whittingham.
Hi, everyone. Sorry that I can't see all of you, but hopefully you can hear me okay. So I'm going to take over from Irini and just go a little bit more into depth by what we mean by coaching. And specifically, the Royal College frames it in the context of coaching to competence. But as Irene mentioned in some of her slides, I think we should see competence as a minimum standard, and really that this is an opportunity to coach to whatever that individual's personal best is, and not conclude at competence if they have the capacity to excel and reach excellence. So I'll break that down a little for you. So you may be familiar with this very intentionally designed model that the Royal College has put out. This is the coaching by design, or excuse me, competence by design coaching model put out by the Royal College. In the middle is the e-portfolio of resident learning. And you can see around that there's a mosaic of different colored small blocks. Those were intended to represent all the different workplace-based assessments that are happening at the time when a resident is being assessed in their environment and provided feedback. You can see at the bottom there, they've divided what we are doing as educators into two types of coaching. One is coaching in the moment, which is really being done by the clinical supervisors at the time that they are observing the trainee or feeding back quite quickly afterwards. You can think of coaching in the moment analogous to a sports coach, so an athletic coach, like a swim coach or a gymnastics coach, who is watching their learner perform and providing suggestions and working with that trainee to move to the next level. The other thing, which is a bit different than what we had been doing up till now, and what we will focus a little bit more on in depth in our cases, is the coaching over time element. That is quite new. This is the concept, if you were to use an analogy outside of medicine, it might be more analogous to executive coaching in the business world, where in this case, what we're doing is we are taking a portfolio of information, all of those workplace-based assessments, and we're using that data to discuss with the resident how they are being perceived, how they're learning, what they've achieved, what they think the next steps are. We are guiding them in their choices of goals and working with them, as Irene had previously mentioned, to follow back and seeing if we're achieving those goals. Before we break those two, coaching in the moment and coaching over time, down into a little bit more detail, I want to pause and speak about coaching feedback. A lot of us have maybe taken courses or some of the program professional development workshops on feedback, and coaching feedback builds on what we were learning in another context. So there are a couple of elements to coaching feedback that are different than what we may have done in the past. So it still involves a conversation between the resident and the clinical teacher. It allows learners, the goal here is less about informing them, however, of how they performed, and more about identifying where they can further develop to keep getting better, even if they were extraordinary. Part of that includes identifying what was learned, or excuse me, identifying what was observed, and then encouraging the learner through discussion to reflect on how they did, what they could do better, and specifically, and this is the very actionable items here, is to goal set. So what are you going to do next time? How are you going to do it? So focusing on specific actions or actionable items that they can do or use, that the next time they encounter a similar situation, or the next time that they are observed, or the next time they are in a clinical scenario, that they can reflect back on that and work towards those goals. And fundamentally, for this to be successful, because it is always associated with what you can do next, it needs to be perceived not so much as an assessment, but more as a identification on the road to learning. It's definitely formative and looking to observe for the purpose of improvement. Next slide. So to go back to coaching in the moment, remembering that this is a key part of our normal learning when we're working in the clinical environment. So this is our workplace-based learning. The idea within the Royal College is that it should be low stakes and frequent. It involves primarily initially making sure that the resident that you're working with, that you have a good rapport and they understand that the goals of this is that you have a shared goal of clinical improvement. So that involves establishing an educational alliance up front, establishing the learning goals and expectations, frequently observing them. Now, you may only be doing the single observation on that day, but overall, it involves multiple frequent observations. I do have in brackets there either direct or indirect, and I have a slide on that next, but it's just a lot of people are initially overwhelmed or put off perhaps because so much of our clinical day is incredibly busy, and trying to squeak in yet more time for direct observation can be difficult. So I'll go into this later, but there are opportunities to provide feedback and frequent observation, which is indirect, that can still be useful. It is related, then you coach on what was either observed or the feedback you observed indirectly. Collaboratively, you work on suggestions for improvement and develop an action plan going forward. So this is just to remind everyone of Miller's pyramid of clinical competence. And obviously, the classroom learning that we do is more on the base of the pyramid, where someone can know or they know how to do something. But our workplace-based assessments are really focused on being able to either show us how or really that they can do it. And so a lot of the competence by design principles really reflect upon whether the resident can demonstrate or do the things that are requested of them or needed for competence. So as I mentioned, there are two kinds of observation. Obviously, we're very familiar with what direct observation is, but it can be really tough to squeeze much more into our clinical day. So obviously, ideally, we would be directly watching a resident as they either assess a patient or do a history and physical. This may be real time, right? So it may be us sitting in the corner of a room, or it may be videotaped, so done asynchronously. We also don't have to watch the entire content. We can watch a small portion of it, right? So it may take an hour to do a complete assessment, but we may pop in for a small portion of part of the physical exam based on what that individual trainee's goals are at the time. But the other side of this that we don't necessarily, we all do, but we don't necessarily consider it under observation is the indirect observations, where we are reviewing the product of that resident's work. We're looking at their clinical notes. We're listening to their presentations of the patient, clinical history, for example. They might write a written reflection. There are also observations from secondary sources. So you may have bedside staff come and compliment or provide feedback one way or the other on your trainees. That is an observation from a secondary source that you can use as part of indirect observation. You may also use a formal 360. So that is another way that you could get observations from secondary sources. So the best thing that we can do is obviously use as much direct observation as possible, incorporate indirect observation and feedback as well, and then use that data to then cycle back to the trainee and use that data, even in the coaching at the moment time, to help them identify what future directions they'd like to take. Coaching over time, on the other hand, is taking that individual coaching in the moment data that has been collated from all of the other workplace-based assessments and using all of those data to reflect back to the resident. So one of the things that's really essential is that the person who's working with that, the academic coach, or some programs are calling them academic advisors, so that person is develops a trusting relationship with that trainee, so that the resident really does feel that the two of you are working together for a shared goal of ultimately excellence in the resident performance. The idea is you regularly review the performance data that you have, soliciting their perspectives as well, synthesizing all of that source of data, and then you are using that feedback in a facilitative way to have the resident reflect back on their progress. You can help the resident reflect using questions. You can challenge them in a way, particularly if they've had some difficult feedback, and you can help them to, through facilitation, to really focus their specific learning goals setting forward. Sometimes residents have very lofty or longer term goals, and so it's very useful to help them to start to develop very concrete, you know, what am I going to do in the next few weeks? What am I going to do in the next few months? Sometimes they have a real idea of the destination, and it's more difficult to focus on the next step, and then facilitate their understanding through the development of these self-guided learning skills. Next slide. So this is the last slide for me, and it's just a pictorial representation that the coach's priority is to help them, rather than having the whole staircase available to them right away, we're helping them to walk up the staircase by putting the things in front of them, meaning helping them to focus on the tasks at hand to enable them to work to the next level. So here I think I'm handing over to Blake to discuss our cases.
Yeah, sure. Thanks, Heather. So just to go on, we're going to do the breakout in just a couple minutes, but for the sake of people who may not have had opportunity to review all the documents that were sent, you should have them in your email to be able to look up. But I'm just going to briefly go over some of the documents so that we're all starting from the same area, and then we'll have those breakout rooms for discussion. So if I can, I'm going to try and share a screen here. Okay. All right, so here's some of the documents. So first you should be seeing here, our first case is Alex Liu, and she's an internal medicine resident who's PGY1. And just to familiarize people a little bit with the dashboard, so this is an example of of the MedSys dashboard, and it contains a bit of information here for us, specifically what stage we're in and the residents in terms of their, right now this residents in Foundation of Discipline, the progress in that stage, and then it has all the different EPAs listed and the milestones that need to be achieved for each of the EPAs. It also has a breakdown of the entrustment scale here. So, you know, I had to talk them through it. I needed to prompt, I need to be there just in case, or I didn't need to be there. So I hope most people are familiar with this or soon to be familiar with it. So it also shows the individual EPAs and again, which ones have been achieved according to that entrustment scale. And then it also shows the individual milestones and the progress for each of those stages based upon how many of those milestones have been completed. So we can see here for the initial assessments, EPA 1, Alex has achieved 11 successful milestones through there. Same kind of thing down here. And then at each EPA, we also have access to all the comments that were put in during the individual assessments. So here we can see that they feel they're competent and no kind of flags are identified there. So each of the EPAs here, as I said, are broken down. So EPA number 2 we see for Alex is not yet completed. And most of that is because we're missing some milestones. Now, what we don't have on this, which we'll normally see in MedSys, is we can actually go into each individual EPA and show each evaluation. And then it also shows us what is missing so that they're not, it also shows what's missing in order to meet that individual EPA. Okay, so sometimes they need more achievements of a milestone to catch up with that. So I'm just going to, just kind of in the sake of time, because I think we want to all get to the breakout rooms, I'm just going to show a couple of things here. At the bottom also there's the ITERs, so there's summaries of each ITERs for the residents that are available. So this is really that coaching over time role, and getting all the information that's been collected and collated through MedSys to allow us to know how the resident's doing from multiple scenarios and perspectives. So here, the specific one for Alex Liu here in her case, you can see that she's achieved most EPAs with sufficient completion of the required milestones. EPAs 2, 5, and 7 still need some work, and specifically for number 7, she hasn't achieved. Sorry, I'm scrolling through here quickly. She hasn't achieved any or attempted any of these milestones yet for this EPA, which is her personal learning needs. But from the rest, we can see she's doing well. I'm just going to move on to the 2 other documents we have for her quickly. One is the coach report, and this is what most programs are submitting to the Competence Committee to really distill some of the information that we have from MedSys. And so here's the overall assessment, looking at each individual EPA of that current stage. And then, as I said, some of these you need more observations. And again, we can't see that, but in MedSys, you're able to dive down and drill down into each individual milestone to see what might be missing. So there's also here a summary of ITERs, and as you can see here, I didn't go through the individual ITERs, but overall, all her rotations actually have been going fairly well, with not a lot of major issues identified, and she's been progressing as expected for most things. Also, we look at other things like medical knowledge exams. So again, trying to get some objective and subjective evaluations present, including getting those comments from individual ITERs. And then comments on scholar activity and learning needs. So, you know, this particular resident, Alex, has started doing a research project and overall has been achieving EPAs as expected, but still are having some issues with getting some EPAs completed. The other piece of data we have here is the resident reflection for her, and I think taking the resident reflection in combination with the coaching report is important in order to be able to come up with the plans that we want to do in our small group activities. So this is the reflection that she has based upon her progress so far, and really, you know, are they able to identify some of their own strengths and weaknesses? And overall, Alex feels she's doing well, but still needs to have more access to procedures to practice them, and she's having some challenges with the actual completion of assessments by staff based upon availability and actually getting them submitted. She feels that she feels there's some barriers there, but she's doing daily learning that she finds useful for herself, but she's asking kind of for more research guidance, which is a little bit addressed in the coaching report. So with this information, I think I don't know if anyone wants to talk a little bit more about the breakout session and where we'll go, but we want to use this as a case to springboard to how we can actually do coaching over time for this resident and help establish some learning objectives and goals for her.
Right, everyone. So this is Naveen Sidhu speaking. I'm just going to wait for a couple more comments to sort of sift through. Our breakout groups, all the facilitators, we're going to bring back some take-home messages and place them in the chat. So everyone keep an eye on it, and then maybe I can start touching on that. So I'll just maybe give it another 30 seconds for everyone to get back in. And then after that, we can quickly go back into the slides. In the meantime, Allison, do you want to go back to sharing the presentation? And then I can go ahead and start my part of it. Thank you so much. All right, so while we're coming back, let's just go ahead and read some of these comments. So Reni's group was mentioning that their take-home points were encouraging multiple attempts before asking for EPA observation and completions. The Competence Committee should look for systemic barriers to achievement of EPAs, encourage a culture of multiple low-stakes assessments. I think that's the most important thing. Like that's the whole purpose of the work-based assessments that we talk about, is multiple exposures, and it's okay that you do a bunch before you know, asking for a specific EPA observation and completion. Another way of doing it is being okay with getting 1s and 2s and going through that process. But the important thing is just do as many exposures as possible. And that systemic piece is really, really important. Part of the coach's job is to advocate for the trainees. We talked a lot about that in our session, was that there are often barriers in terms of getting faculty to complete EPAs, not letting them expire, and really focusing on some of those systems issues. So really important to highlight that. And we also saw that in our group. What we talked about in our group was was that it's just a really difficult task to summarize and synthesize data. Well, you know, I find that the MedSys sort of worksheet is just overwhelming, and it's an overwhelming amount of information. And it takes a long time to really sift through it, synthesize it, develop themes that can then be taken back to a trainee for them to discuss. So that is challenging, and something to keep in mind when you're thinking about how much time to allocate for an academic coach to do their job successfully. Ronish's group said that it was important for coaches to look for areas of improvement and growth, even in residents that appear to be doing well. I think that's a really important piece that was touched on by Irini and Heather. Was we're not coaching to competence, we're really trying to aim for coaching to excellence, and trying to get our trainees to get to their own specific level of capability and achieving their own potential. So once again, it's not just about those check marks of, okay, well, they got this many EPAs. It really is seeing what are they specifically capable of, and how do we continue to coach them even if they do meet all those check marks. Mary's group said, encourage observation in areas where resident is less comfortable to identify areas for true growth. And that's the other piece of what the coach will be doing is looking at themes. You know, what EPAs aren't completed? Maybe there's a reason, maybe they're anxious about that specific area. And really oftentimes we all tend to err to the side of the thing that we're most comfortable with. So how do we encourage trainees to leave their comfort zones and really, you know, work on those things? And part of it is having an appreciation for what their comfort zones are and what they're afraid of. And then Mike had to say that flexibility of competence committee to make decisions based on quality of data. That is also very important, is that, you know, at the end of the day, the specific EPAs and all of that are general guidelines, but the competence committee is the gold standard when it comes to making those decisions. So a really important part. Just going to spend just a couple more seconds before we move on in the interest of time. Basically, Heather's group said, we discussed what to report and how to handle sensitive content. We discussed finding a balance between the EPA and milestone numbers and the narrative surrounding them, and how to use that data to help the competence committee. We also reflected on how the academic coaching role may also include helping residents balance wellness and coaching towards supports that influence academic performance outside of just academics. And I think that's an important piece, and something we'll likely be discussing as well is that context, like where does the performance fit in? There's the medical expert piece, but you know, there's a lot of other factors that can be influencing a trainee. So really being mindful of those things, including wellness, to get us to where we need to. Mary's group also said to try to emphasize the importance of reflection to help identify her learning goals and follow up at regular time points. I think that's a really critical piece. Once again, we're coaching as opposed to telling them what to do. So we may have ideas and you know, likely very insightful ideas as we have experience, but really it is important for them to be able to reflect and come to a lot of those conclusions. And we really have to help them with that reflection piece and guide them through that. Blake's group had said that they felt that there seemed to be a lot more data than we usually get to see for a resident. There was a good discussion regarding resident insight and the utility of the self-reflection as a basis for coaching. So kind of keeping with that theme, that importance of self-reflection is so important to have an idea of, you know, your own clinical insight in terms of how you're coming along. And yeah, it is a lot of data, but once again, it's those low stakes, multiple forms of data that can give you sort of that overall impression. So I think it was a really fruitful conversation. Maybe I'll just pause for one sec to see if anyone has any questions, and then I'll go ahead and move on with my set of slides. All right. So I think at the end of the day, we all had some ideas in terms of our thoughts on that patient. So why don't we go ahead and talk a little bit about what the responsibilities of academic coaches are. I think everyone may have received this document, which had 10 questions, you probably can't see it, but basically it's questions to ask yourselves in terms of what the responsibilities of an academic coach are. You know, in our group, at least, most people were already academic coaches or had that process in place. However, I do find that it is important for us to just sort of take a step back, reflect, see what's working, see what's not, and then share expertise with multiple groups. You know, I think that piece is important. So if we could just go on to the next slide, Allison, and I can, you know, kind of talk about some of those examples. So in the responsibilities of an academic coach, some of the questions that were used were, should there be prerequisite qualifications? How are academic coaches selected? Are they appointed? Is there a maximum number that the academic coach should coach? How long is the term? So lots of different ways. And I really do recommend each program sort of sit through and look at some of these questions to reflect on what you would like to do. So I thought what I could do is provide some examples of different ways that different programs have interpreted what it means. So for instance, one of the questions is how long is somebody the academic coach for a trainee? You can have the same coach for the duration of training versus different alternatives. So in critical care, which is the program that I'm program director for, what we ended up opting to do was having one academic coach for all trainees for their first phase of training. I have the advantage of doing that. We have a small group of fellows. And the reason I did that was we felt that the coachee, probably not the appropriate word, relationship is a really important one. And you have to be able to sort of have similarities in terms of personality or compatibility almost, perhaps an interest in personality and the ways you learn. And so that's hard to know right off the bat and have somebody be assigned to a coach immediately. So what we do in our program is I am coach for every single one of the trainees for that first transition to discipline time. At that time, I get to know a little bit about the trainees, learn about their research interests, their learning interests, their career interests, a little bit about their learning styles. And by then I'll have a better idea of what they need. And then after that, what I do is I look to align them with the appropriate coach for them. Oftentimes the trainees, in some cases, have approached me and said, I would like to have this person as my coach. You know, and that conversation had already happened between the trainee and their future coach. Other times they've asked me for my perspective and I have made recommendations. But basically then what I do is I sort of match them up. I'm the matchmaker that provides them with their coach going forward. And then they carry on with that coach for the remainder of their training. So that's the way we've done it. Some other programs, like some of the 5-year programs, may decide that each person or each coach is an expert on a specific stage of training. So they know their EPAs for foundations in and out, and they're great at coaching trainees through that part of training. And so it may be that a trainee may have 4 different coaches for each stage of training as they progress. And once again, that can have to do with the length of the program, the number of EPAs, and that's something for you as a program to decide. And then some others may decide that, no, this longitudinal relationship needs to continue throughout, and some may decide to do that. There's also other differences in terms of you know, what you call the role of the coach. There, you can call it an academic coach, you can call it an academic advisor. In peds anesthesia, Mike Parrish's group, they're actually referred to as academic advisors. And coaching is really thought of as a shared responsibility between all of the faculty members. And then the designation of the person who follows them through that longitudinal piece is the academic advisor. And that's perfectly legitimate as well. Once again, other things to think about are larger programs versus smaller programs. In larger programs, you may have more faculty, but then you also have more trainees. So there may be one academic coach for 3 to 4 trainees. And then smaller programs have other problems, or, you know, however you want to look at it, different opportunities, in that we often will have to wear multiple hats because there's so few division members. So really, at the end of the day, the piece that we want to say is that look at the spirit of what an academic coach is and decide for yourself and your program what you think works best. And if you already have academic coaches, evaluate how you think it's going and make changes as you see necessary. All right, let's go on to the next slide, Allison. So at the end of the day, each program will decide what is appropriate for them, but the core relationship or the core importance is, at the end of the day, how do you have effective academic coaching? So at the end of the day, the spirit of it is how do we build relationships with our learners to be able to coach them? And in situations, like in all relationships, when things maybe aren't going well, how do you recognize, see those signs, and then how do you work and ameliorate those relationships which may be troubled? At the end of the day, it's a process. And a coach at the end of the day is a person who can help learners reflect on where their performance stands and how to improve. And coaching is beneficial for anyone who is pursuing optimal performance. Coaches can help individuals to do a task better, develop a skill they don't possess, or achieve specific goals. Coaching helps learners understand what adjustments and modifications will allow them to progress. And coaching gives actionable, concrete suggestions for improvement. I think the key piece to understand there is that coach helps the learners reflect on how their performance stands. We all have a temptation to be like, I've been there, I've done this, this is what you need to do. And really, it's more about having the resident be able to reflect and get there themselves with some suggestions and conversation. In CBD, the role of clinical teacher is evolving, and it's going from supervisor to observer and coach. And really, when clinical teachers directly or indirectly observe the residents, what the residents do and the work that they do, these observations actually provide learning opportunities in and of themselves. And Arini talked about this, that it's no longer an assessment of learning, but it's an assessment for learning. So a few brief comments on this process. Some of you may have heard of the RxOCR model. Everybody loves a good acronym, but it really does help explain or helps define that the process that we embark on in coaching, and that's both in coaching in the moment and coaching over time. The key pieces are the first part, which is establishing an educational rapport between the resident and the clinician. That educational alliance, that partnership is really, really key to the progress that you make. It's very important to set expectations for a specific encounter. So that could be expectations for the meeting with the coach. It could be for the specific EPA that's being completed, but expectations are important. And then you observe the resident, either directly or indirectly. Then you coach them for the purpose of improvement of the work that they've done. And it's really, really important to record a summary of the encounter. So this is, like I said, the same for EPAs, but also really important for when you meet with your coaches one-on-one going forward. All right, so this is one way to look at how do work-based assessment really fit into EPA. We know that coaching as a method of teaching and learning for competency progression. From the coaching standpoint, the purpose of work-based assessment, which occurs in the practice environment, must be understood as formative. In other words, for the purpose of informing learning, assessment for learning, not necessarily of learning. And the goal of the workplace assessment is to provide specific feedback to enable resident development. So if you see here, we have a set of expectations that are defined. We said that was really important. And those are our EPAs and milestones. Those are already defined. So we have an expectation of what needs to be accomplished. They then go forth into the workplace, into the practice environment, and start attaining multiple work-based assessments. So multiple observations, verbal feedback, and these all go into an e-portfolio. The coach is then working with them in terms of assessing everything in here and also developing coaching reports, resident reflections, or helping the trainees do that. And then that's what the competence committee uses then to make the decisions and inform the decisions with regard to stages. The documentation of the feedback and the coaching suggestions, which is kept in the e-portfolio, really at the end of the day is what the competence committee then uses. Remembering coaching is about learning and improving performance and not about assessment and judgment. And that's, I think, the key piece and the important piece of why I think CBD is successful. So we talked about the importance of that educational alliance. And really that's the core of the first piece of a successful coach relationship. So how do you build that educational alliance? And really, a lot of it does come down to what is the resident perception? Do they feel that the teacher is interested and engaged? Do they have a commitment to their learning and development? Is there a mutual understanding between the trainee and the coach of what the learner's goals are and how to achieve them? And how the resident's perception of being liked is. In a good relationship, you want to feel that both people are, rooting for each other, and that piece is also important. So, so really, we have to think about how can we demonstrate our interest and how we can demonstrate our commitment to that professional development, and how can we genuinely like all residents that we're working with. And so that's where we talk about how to build those educational alliances. So it's really important to invest time in knowing your resident's story. Learning a little bit about their past experiences, life situations, interests, their goals, because then you can put that into context with how their EPA's achievement and all the others are coming along. So that piece is really important for building that relationship. It's also really important for you to be able to provide some clarity about your role, your expectations, and really your hopes for that relationship. And then, you know, some people talk about this AAA, which is be available, be affable, and be accessible. And doing those three will help you build that and foster that relationship that you need with your trainees. All right, so this is a great diagram that reflects the self-regulated learning cycle. And so those are the colored boxes. Effective learning involves moving through each of these phases. However, it's not necessary to do this on our own, and it can be challenging to do it on our own. And so that's why the gray boxes are there, and they reflect the actions that the academic coach can do to facilitate each step. Relationship building really does underlie that entire process. So anyone, I think most of us who have had a goal setting discussion with learners, or even when we're setting our own goals, know that it's a little bit hard to be able to develop SMART goals. And especially when they're early in their training, and setting concrete and specific goals are challenging. So as coaches, we can help lead through that process of facilitating development of those goals. And the next piece is also in terms of how do you plan strategies and actions to develop those goals. As a coach, you have a clear understanding of what the program has to offer, so you can provide suggestions on how to facilitate those goals. You also want to help trainees understand that none of us can depend on our own sense of how we're doing. So that periodic review and ability to interpret and reflect on data is really important. And as residents mature professionally, they then will need less guidance as they go through these steps. But once again, the coach is there in every corner with the trainee as they work through those steps. So that's a really important thing to emphasize is, again, it's a self-regulated learning cycle. The trainee needs to learn to do that. It's not just about learning the key competencies, it's also learning how to learn. And you don't want to take that away from them. So that, you know, is I would say, you know, a key take-home message that the trainee can then use, or sorry, the coach can then facilitate them through that process. And it does get easier. The more you do it, the more you go down the cycle, the better the trainees get with this. All right, so with that, I think I'll be handing it over.
Perfect. Good morning, everyone. So I'm going to continue on, and what my next few minutes is going to talk about is basically a toolbox for academic coaches. I'm going to specifically talk about the R2C2 model, the GROW model for coaching, coaching feedback grid, and an educational plan with reflection. The R2C2 model is an evidence-based reflective model for providing assessment feedback. Feedback is now being seen as an interaction in which learner engagement, supportive relationships, reflection, and cooperative planning are important. It basically involves 4 different phases. They are fundamental. The first one is relationship building and developing rapport. Naveen had talked about this earlier, and it's extremely important to know your learner and be able to establish rapport. The second stage is exploring the reactions to the feedback. So you could ask your resident, what were your initial reactions? Were there any surprises? The third is exploring understanding of the feedback content. So anything you were unclear about? Did you recognize a pattern? And fourthly, coaching for performance change. What action might you take next time? And this speaks to the growth mindset model, which we spoke about earlier this morning. This provides a strategy for facilitating feedback conversations that promote engagement with performance data and enabling coaching for improvement. Residents can identify performance gaps, set learning and improvement objectives, develop and implement realistic plans to address these objectives, and allows them to assess the plan themselves. The R2C2 model works for both formal and informal feedback sessions. It differs from the traditional approach of giving feedback, which is typically unilateral or unidirectional and top-down delivery. It emphasizes the goal of really being able to help the learner to change and improve, and engages the learner in a reflective conversation about the feedback and how he or she can improve. Obviously, it needs a very supportive and psychologically safe environment, which is extremely important. The limitations, however, as we all know as clinicians, is that it does require a fair bit of time to commit for feedback instead of a brief feedback conversation that you may have. If you invest the time, it is definitely well worth it. Next slide. So the GROW model of coaching is used in many fields besides medicine. It is a useful acronym to guide a coaching conversation. It focuses on the resident and the resident's ideas, although the coach may have other supplemental information as well. The G stands for goal and asks for goals. So you can ask your resident, what would you like to achieve? The R stands for reality and discuss the current present reality of the situation. And you could ask the resident, what has worked in the past and what didn't work in the past? O stands for options, to identify and assess various options that you may have moving forward. W stands for way forward, and definitely it's important to assist the learner in developing and determining what the next steps would be in terms of developing an action plan. The coaching feedback grid, it is gives structure for effective feedback. It was designed by the Bayer Institute for Healthcare Communication. It starts with the learner's self-assessment and encourages problem solving. So you could ask your resident, how do you think you did? It should be based on outcomes that the learner is able to achieve. It is important to be descriptive to avoid making judgments or assumptions. Descriptions can be specific or should be described only what you've seen and heard, and describe behaviors and not personality traits. On this slide, you can see that you can balance feedback by commenting on what the learner should either continue to do, which is aspects of performance that are effective, what the learner should start to do more of, which are practices the learner knows how to do and should start to do more often, what the learner should consider to do, which is a doable challenge that encourages growth, and also what the learner should stop doing, which are practices that are not helpful and could be harmful. It's important to share information rather than give advice to the learner. What I've generally found to be effective is a nice phrase to start out the conversation. I'd recommend that we limit the number of points in this conversation to 1 or 2. Give feedback only to something that can be changed. Make feedback well-timed and placed. Check out interpretations of feedback in terms of, can you tell me what you'll take away from our conversation? And then develop an action plan based on mutual goals. The education plan and reflection I find is extremely important. It is intended to give a guide for residents to set their individual plan together with their academic coach. This can be used to reflect on multiple sources of feedback to date, and it can be used for coaching over time. It is best to determine 2 or 3 specific goals over a certain time period, which the resident would like to achieve. The resident and coach can establish what the learning objectives are, what the trigger or stimulation is for learning, what the timeline is for completion, what resources will be required, what they will need to do to achieve this goal, what are some potential barriers, and how will the outcome be measured for success. Once devised, this tool can be revisited with subsequent meetings of the coach and the learner to determine how successful things have been. And they may actually use this as a stepping stone to set further goals in the future. So I believe the next period is the next breakout session, which I will turn it over to Blake to describe.
Thanks, Mike. So next is another breakout where we'll go back into our small groups again, the same small groups as last time, to have a bit of a different discussion. We'll have 40 minutes to do it, and we're going to try and do it a little bit differently, where we're going to discuss some questions which we have on the next slide, and then we're going to do a little bit of role playing as well to try and put some of those coaching models into action with the resident that we're presenting. So some of the questions, and again, the facilitators will have them, is can you identify the issues that are keeping Joey from progressing? And can you help him develop an education plan or strategies to assist him? Also, how will you proceed to provide Joey with some coaching that will help him with progress? And I think we'll try and talk through that first, and then we'll try some role playing with the facilitators being Joey. Again, like last time, I'm just very quickly going to go over the case so that everybody gets up to speed, and you can certainly ask any additional questions in your small groups. Let me just pull up this one here. So this is Joey Hamilton. So this you should have all received by email. Essentially, Joey's a case of a senior anesthesia resident who's completed his EPAs for core of discipline and is ready for review to promotion to transition to practice, which is the final stage in CBD. So early on during foundations and pre-core, he received a provisional satisfactory due to some deficiencies in his ability to manage emergent situations and some technical difficulties. For that reason, he actually did remediation of those blocks. And at that point, he completed his remediation satisfactorily. He has also made good efforts in terms of improving his knowledge base. So at this point in his training, he's at the same level or exceeding his peers on actual examinations for the in-house and standardized examinations. So here's just some of the instructions here. So again, we'll talk about some of those questions, and then we'll meet as a coach to discuss some of these things. This is the ITER, which we'll base the discussion on for it being unsatisfactory for his neuroanesthesia rotation. And some of the things identified was that the knowledge base was below the expected level, the ability to execute the plan that he's making was sometimes lacking when circumstances were changing. Situational awareness needs improvement. He needed to communicate more clearly for difficult or emergency situations, and it didn't seem that he sought enough feedback despite having a good work ethic. So they felt overall his attention to detail and situational awareness needed improvement, as well as his ability to plan ahead, confidence in his own skills, and also judgment to knowing when to do certain things. We also have organized here his evaluation forms. So these are from his assessors, and they're organized chronologically. So 1, 2, 3, 4. And specifically here, the decision-making and judgment was identified. And there's some comments about that where he was delegating too much and was going down a pathway that was misleading. This next one, again, he's achieving 4s across the board. And they felt he had a good evaluation there. When it comes to later on his rotation, again, they're concerned about his technical skills and his judgment, and he had difficulty with unanticipated situations and confidence to achieve adequate performance. And then as we go on, different evaluators seem to think that he seems to be doing okay, but needs to refine his care plan. Same kind of thing again, we're seeing judgment, work habits and knowledge, as well as teamwork being low on the entrustability scale, and needed to be more confident in managing the unstable patient and be better in terms of their decision making. So we'll stop there and we'll go back to our breakout rooms hopefully, and we'll have some discussion around those questions which your facilitators will have, and if we have time, do some role play.
Okay, everyone, welcome back to the large group. I think we certainly were feeling like we were rushing through that case, even in the 30 to 40 minutes we had to discuss it. So hopefully the other groups had a chance to try to figure out how they can help Joey and to practice some role play with Joey. I'll just take a minute to read some comments from some takeaways from the different groups. So Irini's group thought that coaching certainly takes time and patience, and that a follow-up meeting may be needed, and that's okay. Also maybe knowing your limits as a coach and asking for help beyond that. You know, you're not meant to be psychologists, and you know, at the end of the day, you know, there are limits to what you might be able to do, and to know that that's okay, and that's not your job to fix and solve every problem, but you know, at least doing what you can to help. From Naveen's group, they said the importance of curiosity. So you know, curiosity, I think, to me is another way of saying approaching a problem or a situation in a non-judgmental way. So you're remaining curious. You are trying to think what, why, how, what, when, as opposed to, you know, arriving at the situation already with a preconceived idea or plan of action. So being interested, being engaged, asking questions, that certainly came up in our group. Is, you know, everybody wanted to just know more and more than just what the data was saying, and more about what Joey and why. Some people thought that was fun, and got one from Mary's group here. More time, more meetings, circling back to help create time for additional reflection, allowing Joey to develop ideas and an educational plan. So, you know, I think we're already seeing a theme, and probably with what you've experienced in your groups, is this can be quite a time-intensive job. And, you know, the time might be necessary just to go through the issues that exist and trying to work with the learner to come up with educational plans. But we haven't even talked about the time taken to establish that trusting relationship to be able to do this. So overall, there is going to be a fair bit of time investment between the coach and learner. And so that might go into that idea of, well, how many learners should a coach have? Should it only be one, or should it only be a couple, to make sure that the time is spent appropriately? We've got a few other comments here, and we don't have too many slides after this, so and I think this is part of the interesting part of the discussion, so I'm gonna spend a few more minutes on this. So we identified, group 3 identified several options for Joey, including alternate training location, another block, simulation training to work on crisis resource management, perhaps having a single supportive preceptor. They reflected on the importance of a supportive environment, and, you know, how it can be hard working in, you know, certain stressful environments, and, you know, sort of validating that a lot of people need support in these contexts. And also had a long discussion about what if the supervisor was part of the problem. So yeah, so some thoughts here about, where to go with this. And at the end of the day, even if we do identify the issues, we still need to try and help the resident come up with a plan to move forward and improve their performance. And at the end of the day, be successful and meet their goals, which is to be a practicing, or at least get into transition to practice for anesthesia. From Mike's group, importance of identifying underlying concerns. I think we've brought that up a little bit. And another one, exploring to help Joey in, what happened in past and difficult rotations. I think that was one thing that was, you had less access to than you might have as a coach for Joey, is hopefully as a coach, you'll have some previous background about how previous rotations and assessments and whether things like anxiety or high stress situations have been an issue, and sort of how those were dealt with in the past. And obviously trying to, using all the different coaching models to engage in an open dialogue. So that was the other thing our group also, as Blake brought up, was even if we have an idea of what we think might be going on and how we might want to help Joey move forward, we still need to figure out how to communicate that. And that can be just as challenging, if not more challenging, than any of the other actual content parts of it. So lots of interesting pieces with this case. And I think this is probably not an uncommon situation or a style of issue that a coach might deal with. Great. So I'll just pause here. Are there any thoughts or comments from any of the other group facilitators or anybody else on that they'd like to add before we move forward?
Ronish, it's Naveen. I had one comment that kind of came up in our group, and I thought maybe worthwhile to bring to the larger group.
Yep.
And that was sort of how to delineate the different roles and the different supports that the trainee may have. So one of the questions that came up that I thought was interesting was, if now the academic advisor perhaps has an appreciation of what's happening with this trainee, what are their responsibilities with regard to taking this back to the program director? Should they inform them? Should they be transparent, talk to the trainee to encourage them to take it to the program director? Is that even a necessary step? So that piece of the puzzle, because there are a lot of different people that are sort of involved with the training of this trainee, and at the end of the day, the program director, is the overarching person. So how does that communication between the academic advisor and program director happen? More just a question for everyone.
Yeah, I think that's a good question, and I think that's something that I know has come up even in our program in ICU, and I think it. My feeling on that, which maybe is just a personal one, is, the coach is not meant to be a informant for the program director or for the program. The coach is really somebody who's meant to be an advocate and support for the resident. And to me, that's almost in a way, a confidential, relationship. So I think if the coach would like to, if the coach feels it would be valuable for certain information or anything to be shared with the program director, with the program from the resident side, I think that should be encouraged, but I think it shouldn't be done necessarily, it shouldn't be done without their consent, first of all, or it should actually just be encouraged for the resident to seek that out themselves, as opposed to the coach intervening, as, short of, breaches in, things like suicidality or severe, concerns from that perspective.
I think that was the kind of conclusion that we came to as a group, that the program director may have additional resources that they're privy to with regard to supports for the trainee, and they may be able to help with regard to some of the rotational changes that may have to happen. So for instance, some of these simulation sessions, perhaps moving rotations around a bit. But at the same time, that confidence is important. So what we had kind of compromised on was that encouraging the trainee to talk to the program director and facilitating that conversation, even saying, maybe we'll meet together, but at the same time, making sure you're not betraying that trust and being as transparent as possible, because you don't want to undermine that relationship.
Yeah, we've got a few other comments coming through. So Desi says that the academic coach has a responsibility to move the resident successfully through the program, not a counselor or a mentor. Those responsibilities fall elsewhere. Yeah, absolutely. So as we've been saying all along that, coaching is really to develop those skills to be able to, perform and ideally perform at least competently and independently. And yeah, so we've got other people who think that asking permission to disclose to the PD. So I think it's just really trying to facilitate the, what you think needs to happen in order for that resident to progress with their skills. All right.
Other thing that I would just add on here is the idea that maybe the coach is not best poised to coach for every aspect of training, and perhaps can be seen as more of like the head coach. And that if there's some specific skill sets that need to be developed, whether it's communication skill sets and that requires some coaching, that the academic coach, and I wonder what people think about it, would be the kind of the head coach that goes and engages or hires on extra coaches for that specific skill set or that specific competency, and kind of oversees how that goes, and then and kind of, coaches generally, but then is able to delegate smaller specific coaching tasks to people who may have the skill set for it. I wonder what people think of that. It's kind of like a sports analogy.
Okay. So I might just spend a few minutes to go through these last few slides here, and then we can talk a bit more about some of these comments that are coming through. But we've alluded to these sort of two types of coaching: coaching in the moment, which is more of the workplace-based assessment. I think something that clinicians probably have a fair bit of experience with in their day-to-day work, even before CBME. And then also talking about coaching over time. And I think this last discussion with Joey was more about coaching over time. So I think when you look at, for example, the RXOCR diagram here, it can apply to coaching in the moment, in terms of you're still trying to build that rapport and expectation, even if it's a short period in time. You have to make that observation, and you have to provide meaningful feedback or coaching, and document that or pass that on in as part of the portfolio. And sort of very similar process can be applied, stretched out over time for coaching over time. So there's sort of spectrums of the same idea, but the target observation, rather than being maybe a single act or performance measure, might be an observation of overall trends or performance over time. Right. So I'll go to the next slide now, Allison. So we have a few slides here that show some great online resources for coaches and coaching in general. What you're seeing here is the CBD coaching resources from the Royal College. And so these slides will be available for you or your program to download, including all the cases. So again, the idea that we'd like to have from this workshop is that you, or if there's anybody else from your program who is taking part, that you can use these materials and even run a little bit of a coaching update or session for your own program, adjusted as you needed. So all this material will be available on the Postgrad CBME website, which we'll see if we can just pull that up for you at the end of the presentation. But this will be posted there. So online modules for coaches. So this is from the Royal College. You'll see that all of the different sort of coaching strategies and approaches that that you heard today are there, and there's even MOC credits for participating in the activities attached for each of these types of coaching styles. And within MAC itself, the faculty development office has come up with an actual faculty coaching program, because coaching has become such a huge part of training in all programs, and it's something that is considered extremely important to them. And so Robin Mackin is she was a pediatrics resident who's now completed her training, and whose area of interest was faculty coaching, and so is working with them on coming up with a number of activities to promote faculty coaching, and so that can be accessed as well for anybody anybody within the Faculty of Health Sciences. And then we're just going to end off with a summary of those two sort of coaching styles that we talked about. So, coaching, in the moment, previously we were using terms such as summative assessment, high stakes, something that had a lot of judgment attached to the assessment, and we used to, that was sort of labeled as assessment of learning. And now we're trying to transition that to more what happens in the moment as being observation for learning. And I like the change from the word assessment to observation, because it sort of removes a little bit of the judgment that is typically attached to the word assessment. So you're simply observing, observing whether it's directly or indirectly. You're making an observation because you need some sort of factual information to make your impression and help develop plans on, and it's for learning. And so this, is more akin to formative assessment, although we're using that term less and less often. But the idea is that it's much lower stakes. It's happening more often, so both the learners and coaches are more used to the process and are not as threatened by it. And it really just shifts the goal being to, rather than judging status, as to, okay, we're going to figure out how you're doing now and how we're going to get you moving forward. And so that's the idea of monitoring learning and monitoring progress and being in that constant feedback loop. So coaching over time, although it is stretched out over time, it uses a lot of the same sorts of principles. You're still observing a pattern of either assessments or pattern of behaviors or performances, and going through that same loop, but just over a period of time. And so, one thing Mike said yesterday is coaching over time, it requires time. So it's not something you can necessarily do after a single, review of the portfolio. Maybe it's going to be, you're going to need a year to see in your program, really how the learner is doing. And that's going to depend entirely on the program and the types of performances that you do. So the slide that we have here is showing that part of coaching over time is really building and establishing that educational alliance, because that's where the communication and the trust, when it actually comes to working with the learner to help them grow and help them develop, is really going to be based on a good educational alliance. And at each meeting, even if things are going well, even if they're doing great, you want to reinforce that educational alliance, that there is trust, that you have shared goals, that you are invested in their success. And so that in the future, if there are issues that come up, for example, with Joey towards the end, they already feel that they know that they have somebody who is invested in them and they can trust and they can speak with openly and give that richer information to help come up with plans. So it's always good to not just review their progress, but reinforce that educational alliance as you go along, and then help re-strategize, and then sort of going through that cycle over time. so the similarities and differences in the moment, really we're trying to coach to, whether we say competence, excellence, whatever the goal is for, for the learner and the coach together. Differences, might be that, in the moment you're doing sort of these low stake, we call them observations, but they are intended to, figure out where the resident is at and to provide them that feedback. But then over time, it's less about assessment of them, but being that supportive person to ensure that they are in a process which is going to develop the skills that they need to move forward. And it's more of that longitudinal support. And so we have a few other references which will be available. And I think there was, so that's the link to the main CBME postgrad page. I don't know if, Alison, are you able to pull it up just in case people haven't seen it? So, for those who are just kind of getting into CBME in their programs, or even if you've already been in CBME, postgrad has a nice collection of CBME resources. This is what the main page looks like. Highly encourage everybody, no matter where you are, to sort of have a browse around just so you can see all the McMaster faculty-specific postgrad resources. But this is presumably where the slides from this talk will be posted under the resource tab. You'll find a number of other guides and links and templates found there, as well as archives and any other updates to CBME. And also helpful for me is also some contacts of different people involved in CBME at McMaster. So if you have questions about MedSys or about how to deal with a certain issue in your program, or maybe some help with the program around a coaching workshop or anything, then you've got a number of people here who can help you with that. All right, so I apologize, I wasn't able to keep up with everything going on in the chat there on the side, but I might see if any of my co-facilitators want to bring up any interesting thoughts or comments that they want to share with the group.
It's Lisa. One of the things that we've identified is that the academic coach role might roll into another position in the program, particularly in smaller programs. And I'm wondering if, based on some of the comments there, that it really, you're advocating, or the group's advocating, that it really be a separate role to maintain that relationship and separate it. So a PD wouldn't necessarily be an academic coach or have their roles to play. Just one thing to consider as we work with programs. I think that's a really interesting point. And the other is around, maybe particularly with Joey, the concept of that an enhanced educational plan, and maybe some of the intervention is not punitive. It can be presented as very supportive of recognizing where the trainee is on their competence journey, and that we're getting them and keeping them on track. And that's part of a growth mindset that some of this new model of assessment for learning is trying to espouse.
Yeah, absolutely. And I think, a program that may only have 1 or 2 learners is, with perhaps 5 or 6 faculty members, might be or will be very different than, a program with 50 learners and 80 faculty. It's
very true.
It's very interesting to see how CBD looks so different for all of us, but still has some common themes.
Romish, the other thing I'm noticing as we look through the comments, I think is the exciting part of CBD, that it could be really innovative. One of the things that James had brought up was, could there be specialist coaches for specific skills that you could kind of refer out to? For instance, if it's a communication problem, maybe there's a specific person that they can touch base with, and that coach could help facilitate hooking them up with, X, Y, and Z. my thought on that was also that, you know, I think it's important to think outside the box. You know, we have a thought that we need to maintain within a specific specialty, within critical care or whatever it may be, but maybe knowing that a lot of those skills are transferable, and perhaps reaching out to resources that aren't necessarily in your division or department, especially for the smaller programs, for some of those specialty skills as a potential. There's also lots of sports analogies going on in the background.
Yeah, and I think, you know, aside from perhaps even just finding expertise outside of your own program, you know, in some ways, maybe the resident and or the coach might even feel a bit more comfortable, you know, working on what they need to work on with people who are not their direct supervisors in the clinical sphere. You know, it kind of might give them that little bit of arm's length distance between, you know, people supporting them and working on issues as well. All right. I'm not sure, Rini, if we had any other specific material you wanted to go to. It looks like we're just coming up to noon, I'm sure.
No, so I was just going to say that we've kept our commitment to ending by noon. It's 11:56, and there's been some really great conversations, both on the chat and in the individual Zoom rooms, that have really made this workshop successful. Really, at the end of the day, we know that a lot of people around the Zoom table are already coaches and have been coaching for years, whether they've had the official title or not. And today was really just to, number one, give everybody a toolkit that you can take back to your programs, so that you can coach and teach other coaches and think of what areas of faculty development are needed in your role, whether it's the PD or competence committee chair or coach, to make coaching more effective and to make that feedback effective coaching. And really to thank everybody for coming and for staying until noon and supporting us in this first Zoom workshop for academic coaching. There's going to be other offerings from the CBME Faculty Development, in terms of, we had a really nice retreat that was planned in April, but we've made obviously the decision to cancel it and reschedule it to the fall. So it's going to be probably smaller chunks of Zoom workshops and some webinars. So keep your eye out for those. If you have any questions, all of us facilitators are very happy to receive any questions, emails, let us know. And there is an evaluation. We really do want to hear your feedback about how we can do this even better for next year, that Alison Paquette from CBME office will be sending out by email to everybody who participated. So please take a couple of minutes to fill that out and let us know your feedback.